Hello, everyone. My name is Wendy Trafton, Deputy Director of Healthcare Reform at the Vermont Agency of Human Services. Thank you for taking the time to learn more about Vermont's recent and ongoing healthcare reform efforts. This presentation will be split into two parts. The first part provides an overview of Vermont's healthcare reform goals and efforts, and how the new federal program called States Advancing All-Payer Health Equity Approaches and Development, or AHEAD, fits into those efforts. The second part of this presentation will provide a deeper dive on Vermont's application for the AHEAD model, which was submitted in March 2024. Part 1. Vermont's healthcare reform efforts. The state of Vermont is working to improve healthcare. Our goals for improving care are to make health insurance and healthcare affordable, ensure Vermonters can get care when it is needed, improve the quality and experience of care for Vermonters, improve work life for healthcare providers. Providers want to deliver the best care for their patients, but they often struggle to do so in our current healthcare system. And keep all Vermonters healthy and well. Some groups of Vermonters have worse health due to where they live, or a disability, or their race or ethnicity, or their sexual orientation. New approaches are needed to close these health gaps. We have many strategies that we are using as we work together to address healthcare challenges and achieve our goals. We want to identify ways to improve how care is delivered. To do that, we collect and use data about healthcare to learn how to improve it. We change government policies and rules to support these improvements. We also change the way we pay for healthcare. Often, we give providers more money when they deliver more services. But more services may not be the best way to keep us healthy. Instead, we can study methods proven to deliver care that keeps us healthiest. Then we design new ways of paying for the best care. Many of the strategies we used over the last 2 years were focused on helping the healthcare system get back to normal after the COVID-19 pandemic. Many people waited to get care during the pandemic and had worsened health. Providers had financial troubles. Many of these financial troubles continue today due to increasing costs for staffing and materials. This made it even harder for providers to care for the greater needs of their patients. In response, the state of Vermont has increased annual payments by $164 million to support our healthcare providers. The state has made these Medicaid payments across the health system over the last 2 years. We also know that Vermonters need better access to mental health care and substance use disorder treatment. People need options for getting assistance with self-care and everyday tasks. Vermont is making investments in these key areas to improve the healthcare system and undo many of the challenges caused by the pandemic. Let's focus on 5 examples where we have done that. 1. Mental health crisis system of care. We're strengthening the mental health crisis system of care through the 988 Suicide Prevention Lifeline. We're providing more face-to-face services to people in crisis where and when they need them. We're opening community-based mental health urgent care programs across the state. 2. Certified community-based mental health and substance use centers. We are improving community-based mental health and substance use care to provide coordinated treatment for people of all ages. We will increase access to a range of services by working to eliminate wait times, offering evening and weekend hours, and providing immediate crisis care. Services will be available to everyone who needs them, regardless of their insurance. 3. Substance use disorder. We are improving care for people with substance use disorder. We're doing so in primary care settings and in the community. We are expanding who can receive services through Medicaid, expanding community health teams within primary care, so community health workers, counselors, and social workers can provide services on site. They can link Vermonters to ongoing mental health and substance use disorder treatment, as well as supports to get food and housing and other social needs that impact health. empowering community providers to fully treat Vermonters with both substance use disorder and other physical, mental health, or social needs. 4. Older Vermonters and people with disabilities. Older Vermonters and people with disabilities often need support to perform self-care and everyday tasks. They want options for how to receive this support. Those who want services in nursing facilities, especially those with complex care needs, can struggle to find a place. We're opening a new skilled nursing facility that specializes in complex care. We provided tax relief to home health agencies that support people to live independently at home. We're updating the way we pay skilled nursing facilities to improve their financial stability. And we gave grants worth over $17 million to home and community-based providers and local organizations. Some grants fund projects to improve quality of care. Some are improving aging buildings where they provide care. And others are helping find, train, and support staff so they can continue providing community-based care. 5. Workforce. We're partnering with healthcare employers on new programs to grow Vermont's nursing workforce. We're creating a healthcare workforce data center to better understand and solve workforce challenges. Vermont is also exploring a new program with the federal government because healthcare works best when all insurers change the way they pay together. The program is called the States Advancing All-Payer Health Equity Approaches and Development Model, or AHEAD. AHEAD allows states to partner with the federal government to improve healthcare for people with Medicare. Medicare is federal insurance for people 65 or older, and some people under 65 with certain disabilities or conditions. AHEAD aligns Medicare with other healthcare insurers, like Vermont Medicaid and private insurance. Examples of private insurance are Blue Cross Blue Shield of Vermont and MVP Healthcare. The state of Vermont recently applied for AHEAD. This was the first step. Next, the federal government will review all applications. Then they will decide which states to consider for the AHEAD model. AHEAD would create a partnership between Vermont and the federal government. The partnership would focus on Medicare joining Vermont's efforts to improve access to high quality and affordable care for everyone. It would align with Vermont's healthcare reform goals for hospitals and primary care. It would enable Medicare to pay hospitals in alignment with other insurers, like Medicaid and private insurance companies. Currently, Medicare payments to hospitals can change from month to month. Without consistent payments, hospitals can have a hard time managing their finances to provide the wide variety of services needed in their communities. Under AHEAD, Vermont's rural hospitals would have reliable financial support for the services they deliver. AHEAD would also provide flexibility to hospitals. They could focus on providing timely, personalized care in the right setting. They could focus on keeping people healthy and well. AHEAD would also enable health insurers to better plan for the cost of care that they cover. Better planning can make insurance more affordable for Vermonters. AHEAD would make additional Medicare payments to primary care to improve coordination of services and quality of care. This means we would gain greater access to coordinated, team-based healthcare services. These services treat the whole person, including mental health and substance use disorder treatment needs. AHEAD would allow the federal government to continue paying for support and services at home, or SASH. SASH is a program in Vermont that helps people with Medicare stay healthy and live at home. Medicare would also continue to help pay for the Blueprint for Health, a statewide program that brings together high-quality primary care and community-based care. AHEAD would also focus on health equity. It aims to make the best possible health care available to everyone. That includes closing the gaps when some groups of Vermonters experience unequal health outcomes. It would also encourage providers to take a broader view of all the factors that impact our health. Such factors include housing, food, and transportation. The state of Vermont applied to be in the first group of states for AHEAD. We expect to hear if our application was selected in late May or June. We would have an 18-month period to design the program in a way that works for Vermonters. During this time, we would also work with providers to get ready for the changes. The program would start in January 2026 and be in place for up to 9 years. If Vermont is selected, we would work closely with the federal government to define the agreement. This agreement would need to be finalized and signed by both the state and federal government by July of 2025 to move forward with AHEAD. The state would continue to work with providers and the public to make sure this is a good opportunity for Vermont before moving forward. In the meantime, we will continue to make investments and improvements across all areas of the healthcare system. Continuous improvement is a fundamental part of Vermont's overall healthcare reform strategy. Thank you for your time. Please view Part 2 of this presentation for a deeper dive into the details of AHEAD and what was included in Vermont's AHEAD model application to the federal government. Part 2, Overview of Vermont's AHEAD application. Currently, the state is participating in the Vermont All-Payer Accountable Care Organization model, Vermont APM, which allows Medicare to join Medicaid and commercial insurers to pay differently for healthcare. The model relies on an accountable care organization, or ACO, to achieve these goals. An ACO is a network of healthcare providers that choose to be accountable for the care and cost of a group of patients. This model will end in December 2024, with a possible extension in 2025. Recently, the Centers for Medicare and Medicaid Services, an agency of the federal government, has signaled that it is moving away from state-specific models, like Vermont's current model, and is moving towards models that can be implemented across multiple states. A promising alternative to Vermont's current model is the AHEAD model. AHEAD presents an opportunity for Vermont to continue its partnership with the federal government through CMS to build a high-quality healthcare system for Vermonters. As you can see on this slide, the AHEAD model has many different components to improve population health, advance health equity, and reduce the growth of healthcare costs. Key components of the model are hospital global budgets, where hospitals in participating states will be paid a fixed amount of revenue, or a global budget, to provide services to traditional Medicare beneficiaries for the upcoming year. Primary care AHEAD, where primary care practices in participating states can sign up to receive a payment from Medicare to provide coordinated care to Vermonters with Medicare coverage. And finally, CMS will provide each participating state up to $12 million in funds to support planning activities during the pre-implementation period and initial performance years of the model. CMS designed the AHEAD model to allow for significant flexibility for states, enabling them to build on existing state efforts. First, the model would allow states with hospital rate or budget setting authority, like Vermont, to create their own methodology for Medicare hospital global budgets, subject to CMS approval. Second, participating states could have some flexibility in selecting the quality measures that participating primary care practices will be held accountable to under Primary Care AHEAD. CMS must approve the measures. Finally, states would be able to work with CMS to set required statewide accountability targets, including an all-payer total cost of care growth target and an all-payer primary care investment target. The targets and how they are calculated will be included in the state agreement. On March 15, 2024, Vermont applied for the AHEAD model as a Cohort 1 participant. If CMS selects Vermont to participate in the model, and if Vermont chooses to accept the terms of the agreement, the state would begin implementing the model in January 2026. As part of the application, states must describe current capabilities and experiences that have prepared them to implement the AHEAD model, as well as their proposed approaches to implementation. For the past several months, the Agency of Human Services worked with state partners, including the Green Mountain Care Board and the Department of Vermont Health Access, to develop the application. Vermont's application was informed by feedback from healthcare providers, payers, and other interested Vermonters. Vermont demonstrated its readiness to implement the AHEAD model in its application by highlighting its history of successfully implementing complex multi-payer healthcare payment and delivery reforms, including the Vermont All-Payer ACO model and the Blueprint for Health program. Vermont's application covered 5 areas in detail: hospital global budgets, primary care transformation, health equity, statewide accountability targets, and stakeholder engagement. Hospital global budgets are a key component of the AHEAD model. Global budgets provide hospitals with a fixed amount of revenue for facility-based inpatient and outpatient hospital services for the upcoming year for a specific patient population. Global budgets encourage hospitals to reduce avoidable hospitalizations, improve care coordination, and proactively redesign their services to meet the needs of their communities. If Vermont implements AHEAD, participating hospitals would receive a global budget for traditional Medicare beneficiaries from CMS. Traditional Medicare, sometimes called Original Medicare, is offered directly by the federal government. It does not include Medicare Advantage, which is offered by private insurance companies and is considered commercial coverage under this model. Hospitals that serve traditional Medicare beneficiaries would be eligible to switch to global budgets. Global budget payments will include additional financial incentives for hospitals that choose to participate in the early years of the program. Vermont Medicaid has taken steps to begin paying hospitals this way through some of its current payment reform initiatives. Vermont's commercial payers would also be expected to implement global budgets. In March 2024, CMS released its proposed Medicare Hospital Global Budget payment methodology. This document provides a detailed description of the methodology and payment features of Medicare hospital global budgets under the model. States with hospital rate setting authority or hospital budget setting authority, like Vermont, have the ability to customize CMS's Medicare hospital global budget methodology, subject to CMS approval. Vermont plans to take advantage of this opportunity. As part of the application, states are required to discuss their prior experience with population-based payments, state whether they intend to customize the Medicare methodology, describe their planned approach to implementing global budgets in Medicaid, and discuss their approach to hospital recruitment for the global budget model. Vermont's response touched on several key elements. First, Vermont provided an overview of its prior experience with population-based payments, which are prospective payments based on a defined population and are similar to global budgets. Vermont has experience with population-based payments under the Vermont All-Payer ACO model. The current model supports risk-sharing arrangements and population-based payments that flow through the state's sole all-payer ACO to participating hospitals. For ACO-attributed Medicare beneficiaries, hospitals can already elect all-inclusive population-based payments. Medicaid also already has experience testing global budget-like arrangements. Second, Vermont indicated that it intends to develop its own hospital global budget methodology for traditional Medicare. Next, Vermont also noted that the state's Medicaid program intends to develop a Medicaid hospital global budget methodology. Vermont Medicaid would work with its contracted actuaries on developing a Medicaid hospital global budget methodology, expanding on work it is already doing. Finally, Vermont provided an overview of its approach to hospital recruitment. Vermont has been engaging directly with hospitals to solicit feedback on their participation in hospital global budgets through group forums and individual meetings. Vermont plans to continue these meetings during the pre-implementation period. Based on hospitals' feedback, the state is conducting hospital-specific financial modeling to provide each hospital with information regarding the anticipated financial impact of adopting hospital global budgets to inform their decisions. In states participating in AHEAD, Primary Care AHEAD will be a voluntary program for primary care practices, including federally qualified health centers and rural health clinics. Participating practices will be paid a Medicare Enhanced Primary Care payment in addition to fee-for-service payments for traditional Medicare beneficiaries to support improving coordination of care, integrating mental health and substance use disorder treatment, and identifying and addressing health-related social needs. Practices must meet care transformation requirements, which are intended to align with the state's existing Medicaid care transformation efforts. An average of $17 per beneficiary per month for traditional Medicare beneficiaries will be paid to practices on a quarterly basis. A portion of this payment, starting at 5% and scaled up to 10% by performance year 8, will be at risk for quality performance. At the start of the program, CMS will not offer a prospective payment model, known as primary care capitation, that combines fee-for-service and per-beneficiary per-month elements into a single payment. However, CMS has stated that it intends to introduce this option later in the model. As part of the response, states are required to describe their current Medicaid primary care transformation program, including the role of federally qualified health centers and rural health clinics, describe tools to increase overall investment in primary care and improve access, and discuss their approach to primary care practice recruitment for Primary Care Ahead. In its response, Vermont described its current program, policy levers, and approaches to recruitment. First, Vermont highlighted key features of the Blueprint for Health, the state's long-standing healthcare reform initiative focused on changing how healthcare is delivered by providing Vermonters with integrated health and human services and advanced primary care. The Blueprint is a multi-payer initiative that includes Medicaid. Through Ahead, Vermont would build upon the Blueprint. Most primary care practices, 130 practices out of approximately 160 to 170 total practices, participate in the Blueprint, including all hospital-owned practices, all federally qualified health center practice sites, all rural health clinics, and most independent practices. Blueprint includes a patient-centered medical home payment model and 13 community health teams across Vermont, which augment the Blueprint practices services. In July 2023, Vermont launched a 2-year pilot, which aims to expand screenings for health-related social needs, mental health integration, and care coordination. Vermont also described its policy levers to increase primary care investment. Vermont has not yet set minimum primary care spending targets. However, the state completed significant work to define and quantify primary care spending across all payers and is prepared to adopt minimum spending targets. The Green Mountain Care Board's rate review authority and authority to set payment reform methodologies would support the development of primary care investment targets and increase spending. Finally, Vermont indicated that it seeks to take a phased approach to primary care practice recruitment. Vermont's goals for recruitment into the Primary Care Ahead program are all employed practices from participating hospitals, 5 new federally qualified health center and rural health clinic sites per year for performance years 1 to 4, and at least half, approximately 65, of the Blueprint participating practices by the end of the model. The Ahead model has a strong emphasis on improving health equity. To achieve this goal, the Ahead model requires states to develop a state health equity plan and quality targets, prioritize safety net provider recruitment among hospitals and primary care providers in the Ahead model, adjust provider payments for social risk to increase resources available to care for under-resourced populations, and use health-related social needs screening among hospitals and primary care providers. Through the application, CMS seeks to understand state strategies to improve health equity, states' requirements and investments to identify and address health-related social needs, and how the state intends to use various components of the Ahead model to meet health equity objectives and program requirements. Vermont's response highlighted the state's current efforts to identify and address health disparities and its proposed approach to promote health equity under the Ahead model. First, Vermont has several mechanisms to identify health disparities across the state. through the Vermont Health Equity Advisory Commission, state health assessments and state health improvement plans, hospital community health needs assessments, and health equity community needs assessments. These efforts inform the development of health equity strategies for the state. Next, Vermont has an array of care delivery programs and initiatives to address health disparities. Vermont's care delivery programs have a health equity focus, with initiatives like the Blueprint, including the 2-year pilot, programs under the Section 1115 Global Commitment Demonstration, such as supportive housing assistance, care management programs, such as the Vermont Chronic Care Initiative, and certified community-based mental health and substance use centers for those with complex needs, and funding for health equity trainings for providers and health systems. Additionally, Vermont is making significant investments to address health-related social needs, including a grant program to provide funding for eligible providers to integrate health-related social needs screening tools and data into their workflows, incentive payments to eligible home and community-based services providers to purchase data systems to connect to the Vermont Health Information Exchange, and incorporating race and ethnicity data into Vermont's all-payer claims database. Finally, Vermont indicated that it intends to use a portion of the cooperative agreement funding to support ahead stakeholder engagement, which I'll describe later in the presentation, statewide health equity plan, health system capacity building initiatives, and to provide technical assistance to participating hospital and primary care providers. Under the AHEAD model, states will be accountable for 2 types of statewide targets. The first type is focused on controlling the growth of the total cost of care for Medicare and for all payers, Medicare, Medicaid, and commercial. The second statewide target aims to improve investment in primary care. There will be traditional Medicare primary care investment targets that are comprised of annual improvement targets throughout the implementation period, and a final primary care investment target by the end of the implementation period. There will also be an all-payer primary care investment target. Participants will also set statewide quality and equity targets in collaboration with CMS. States will be accountable for performance on selected measures over time. They must monitor and improve performance for identified subpopulations experiencing disparities. As part of the response, states are required to describe their plan for measuring total cost of care and primary care spending for all payers, describe their plan for memorializing total cost of care and primary care investment targets in statute, executive order, or regulation, explain regulatory and policy levers to use for enforcement of total cost of care cost growth targets, and anticipate challenges for meeting total cost of care and primary care spending benchmarks. Vermont's response to application questions about statewide accountability targets focused on the following key elements. First, Vermont highlighted its experience with measuring and reporting on statewide accountability targets under the Vermont all-payer ACO model. The Green Mountain Care Board has measured Medicare and all-payer total cost of care since 2018. The board has authority to require collection and reporting of data to calculate total cost of care from insurers, providers, and state government agencies. They would continue this work with AHS under AHEAD. The Green Mountain Care Board would also use this authority to collect data to calculate primary care investment. In the application, Vermont indicated the governor intends to codify the process for establishing all-payer total cost of care and primary care investment targets via executive order. Vermont also indicated that the Green Mountain Care Board's authority related to hospital budget review and rate review have been and would continue to be Vermont's key regulatory levers to achieve total cost of care growth targets. Finally, Vermont highlighted key anticipated challenges with meeting total cost of care and primary care spending benchmarks. Vermont has very low Medicare spending at baseline and may be challenged to further reduce Medicare total cost of care growth. Vermont is also experiencing challenges related to patient flow through the healthcare system, particularly around post-acute care, which is often needed to recover from an illness or manage a disability, and mental health and substance use disorder treatment. Addressing these issues will require further discussions between CMS and Vermont on how the targets will be set. The model includes a structure within the state for communication and consultation with stakeholders to inform model activities. The state structure must include representation from relevant state agencies, community-based organizations, patients and consumers from underserved communities, healthcare payers, clinicians, and provider organizations, and other entities whose policies influence population health. The state must work with stakeholders under the structure to provide input on the selection of statewide population health and quality measures and equity targets, develop the statewide health equity plan, and assist with review of participating hospitals' health equity plans, provide input on use of cooperative agreement funding, and ensure implementation of the model is informed by diverse perspectives. As part of the response, states are required to describe how AHEAD resources will support creation of the stakeholder structure, provide an overview of the composition of the planned stakeholder structure, and provide the vision for the role that the stakeholder structure may play in planning and implementation of the model. In the application, Vermont provided an overview of its approach to stakeholder engagement. First, Vermont proposes creating a new subgroup of the AHS Healthcare Reform Workgroup to guide AHEAD model implementation. The group would be convened by the AHS Director of Healthcare Reform, Medicaid Director, and Vermont Department of Health Commissioner, or their designee. The group would be comprised of representatives from the Green Mountain Care Board, Department of Financial Regulation, Office of Rural Health, participating provider organizations, commercial or Medicare Advantage payers, the Health Equity Advisory Commission, and groups with known disparities in Vermont. AHS intends to allocate cooperative agreement funding resources for the new group by hiring a new AHS AHEAD project director, who would support the group in general stakeholder engagement, funding special accommodations such as interpreters, and offering optional trainings to ensure robust participation in the stakeholder structure. The funding would also be used for community meeting spaces to support in-person meetings and providing grants or contracts to advance the health equity goals described in the statewide health equity plan. Vermont envisions that this group will review and advise on overall progress of model implementation, provide input into the selection of statewide measures and targets, contribute to the development and review of the statewide and hospital health equity plans, and provide input on allocation of funds for equity activities. For more information about the AHEAD model, please visit the CMS website at cms.gov/priorities/innovation/innovation-models/AHEAD. To view Vermont's AHEAD application, please visit the Vermont Agency of Human Services website at humanservices.vermont.gov/AHEAD-model. Thank you.